All right. Hi, everybody. Welcome to Webinar Wednesday. This is Carly Andrews. I am the Senior Project Coordinator for the North Dakota Brain Injury Network. We do these webinars every other Wednesday. Sorry, I'm trying to play with my settings a little bit here. There, I want it like that, so she could, yeah. Okay, so yes, so we hold these webinars every other Wednesday. They are recorded and archived, so you can view them at any time. You can get CEUs after, so when the recording is up, then the CEU link will also go up as well. So just come back in a couple days. Usually, I can't guarantee it will be up though. I would say by Monday at the latest, just because we are technically off. I don't know if my web team is on or off today. We're kind of, if we're working, it's voluntary. So so I can't, yeah, hopefully by Monday at the latest your link will be up, but otherwise, yeah, keep coming back. We have a lot more scheduled for April and May, and scheduled one for this morning for November, so keep coming. But yeah, we are excited to have Amy Kemp with us. She is a PhD candidate at the University of Georgia and recent awardee from the Brain Injury Association of America's Dissertation Award. She's going to talk to us about the study that she's been working on with fall prevention, and kind of that is the leading cause of accidents in older adults, and the leading cause of brain injury as well for older adults age 65 and older. So the study is going to give us some tips and how we can use that fall prevention and apply it to our lives. So we're so excited to have you, Amy. Thank you. Turn it over, and she will take questions throughout. So if you want to ask throughout, you can, or if you want to wait till the end, that's okay too. So she's not picky.
Nope, I'm not picky. Yeah. So I did make this presentation for a variety of audiences, and Carly told me that this was mostly providers on today. So if you have more specific questions about my intervention, please let me know. I didn't include all of those details just because this is an ongoing study, but I am happy to talk about them more informally. So interrupt me, ask me at the end, all of those things are all okay. My name is Amy. I did meet all of the requirements to get my PhD. All I need is a diploma. And so I'm pretty excited about this. This study, the results I'll show you is what I used to get my requirement for my dissertation. And the grant that I received, the dissertation grant, is expanding on that study, specifically to focus on older adults with brain injury and compare that to older adults without brain injury. So I will go through this. So my area of expertise is in cognitive communication rehabilitation in older adults and implementation science. And so I really look at how thinking, memory, attention, and specifically executive functioning contributes to people's self-management after injury. And this is both with traumatic brain injury and from neurodegenerative diseases, or the combination of both. So I do specialize in both. I am a speech language pathologist by trade. I practiced for about 4 years before returning to get my PhD. And then I continued to practice while I was in my PhD program. I also focus on implementation science, which is intentional considerations of how interventions should be provided in order to make them effective in clinical practice and for the people we are providing them for. So that's a pretty big area of interest that I have, and I'm very intentional on when I study that and take measurements on those factors. This study is on fall prevention, and I'm just going to start by giving some facts on why is it needed. So there are 36 million falls reported by older adults every year, and these are just the ones that are reported. So there might be countless more that older adults are not disclosing for because they didn't result in an injury, or maybe because they have embarrassment about them. And so that's still a huge number of 36 million people or falls that are occurring. And of those falls, 1 out of 5 results in an injury, such as a broken bone or a head injury. And for our older adults that are 75 and older, 26.5% of them die from that head injury. So it's pretty alarming data. A few other facts about older adults in traumatic brain injury. 47.9% of our ER visits are from unintentional falls. And 30 to 40% of older adults in the community have reported a fall, and 10% of those result in that significant injury, like the broken bone or the head injury. And older adults have the most reported unintentional falls resulting in traumatic brain injury. So there is a bimodal occurrence of unintentional falls. So our youngest people, our really young toddlers have unintentional falls, and then our older adults have those falls. And there are some reasons for that. So older adults biologically, as we age, we have decreased physical and cognitive abilities. This makes us more susceptible to injury or complications from an injury that might otherwise be mild in a younger age group. So biological response mechanisms, like how the brain heals, are also less efficient as we get older. Pre-existing neurological comorbidities that occur with age also increases the risk of falls and subsequent traumatic brain injury and complicated results of that. So older adults with cerebral vascular disease, high depression symptoms, low blood pressure, diabetes, insomnia, these are all conditions that can increase fall risk. And we also see them more prevalently in older adults. And when older adults have these premorbid conditions, they are at reduced independence from activities of daily living and also have a higher incidence of brain injuries. So there's multiple factors going into what makes older adults at a higher risk for falls and subsequent traumatic brain injury. We can also talk about people who are aging with brain injury, that they have premorbid vulnerable biological responses at baseline. So they have an increased susceptibility to neurological disorders like Alzheimer's, and this can increase further risk for falls. So people with a history of brain injury also at higher risk for falls. And if you add on age to that, there's even a bigger susceptibility. And then that recovery from falls is more complicated and difficult. So I would like to share some facts, not really to scare anyone, but more to impress the seriousness of fall prevention. And I said at the beginning that I very intentionally try to provide information and study things that provide power back to people, back to clinicians, provide education or resources. And one way to do that is through prevention. So fall prevention and ways that we can reduce risk is where I'm going to sit for the remainder of this presentation. So fall prevention components are composed of multiple things. One is to have appropriate assessment tools. This is looking at both physical, cognitive, and home environment assessment. And they're then moving to risk stratification. So how do we use those tools to establish someone's risk and then provide additional information on how to reduce falls or to maintain that level of low risk for a fall? So we can look at environmental modifications, making a home safer, making access to resources, those sorts of things. We can look at doing that as a prevention. We can also look at exercise interventions, increasing strength and balance, as well as access to those resources. And then foot and eye evaluations are one way to provide intervention to reduce falls. So looking at foot health, nail health, looking at podiatrists, and then eye health, making sure that there is nothing impeding that depth perception or blurred vision, those sorts of things. So this is the Center for Disease Control, Stopping Elderly Accident Deaths and Injuries, or STEADY. This is the handout that is provided. So STEADY is an initiative that can be implemented into clinics. There is a nice system of how to provide information, how to look at risk stratification, how to provide education, and these are the handouts that are provided to older adults. So this is the actual handout that can be given to a patient or a client. And this is also the handout I used in my study. So I did give this to older adults. I allowed them to look it over, to learn from it. And then we talked about the different things on this handout. So the four main things that are provided by the CDC study handout are to review medications with a healthcare provider, to exercise to improve strength and balance, to have your feet and eyes checked, and to make your home safer. So those are the four major things. And there's a double side to this handout where it provides more information. And then this is the CDC study risk stratification. So this is an algorithm for providers. The older adult answers 12 questions, which then can be scored, and they're placed into different risk assessments. So there's low, moderate, and high risk, and then there's information for providers on what they should give to that older adult. So in our low risk, we have educating patients. There is supplements that might be recommended. This is provider specific. And then referring to strength and balance exercise programs, whether that be community, fall prevention educations, physical therapy, those sorts of things. Moderate risk has something similar, although it increases that referral to PT. So rather than just maybe do something in a community setting, but now it's referral to an actual PT to focus on gait, strength, and balance, as well as maybe that community program, just depending on what that client's risks factors might be. And then the last one is high risk, which are where you more in-depth investigation on what is causing falls might be recommended. So really looking at risk reduction behaviors, maybe implementation of an assistive device, those sorts of things. As well as everything that has been recommended before, referral to a PT, but also a much more in-depth evaluation of the patient. So a more physical exam, maybe a more cognitive exam. These are things that should be done at a high risk place in order to decrease the risk to a moderate or to a low. However, something that we see when we provide someone with their fall risk is that people in low risk then don't do anything. And so their risk continues to grow. They think because they're at a low risk that is where they'll maintain. However, they still need to engage in fall prevention activities such as that community referral. And so that is something that I really looked at investigating. And so when you look at my study purpose, this is written as a research purpose. So it's to investigate the acceptability, appropriateness, and feasibility of fall prevention education specific to the CDC study handout. So in other words, this is what I looked for. How is health education currently being presented to older adults? And is that the best way to do it? How do older adults and clinicians think about how health education is provided and how can it be improved? So 90% of primary care providers report that they do discuss fall prevention, specifically at the Medicare, Medicaid annual visit, but specific suggestions and standardized practice is not there yet. And so this means that different conversations occur at different levels. Not everyone is provided with a risk assessment or a full assessment. There are no standardized recommendations for when someone should be referred to PT or maybe speech language pathology for cognitive deficits. And so the prevention is really placed on that older adult to implement independently. And deciding how and when and how can they do these things can be difficult. And that speaks for all prevention. So given the high incidence and mortality risk with falls and brain injury, there needs to be a consensus on geriatric specific guidelines. And this is something that I aimed to contribute to. So I included older adults, specifically those with brain injury as well, into treatments in order to better inform development of clinical guidelines, as well as took data from clinicians. Speech language pathologists administered this intervention. And I took data from them to understand how they felt about the intervention, how they felt about providing the education, how working with specific clients or individual clients might have been appropriate for that education, and when more or less might have been needed. So now I'm going to talk about my ongoing study. The data here presented was used for my dissertation. However, I'm continuing to collect this data, specifically focusing on older adults with traumatic brain injury. So my participants, I had 16 participants who completed the two-part study. I had no dropouts, which I think speaks to maybe the enjoyment or the willingness or wanting to learn. There could also just be a bias, right? But I had very high involvement in my study. All 16 people were white and college educated, and the average age was 74. I had 4 males and 6 people with a history of traumatic brain injury. And you can see here that my sample is very homogeneous, white, female, and college educated. And although this can be a really nice starting point, collecting data from a diverse group of people can make a study more relevant to people that might benefit from the results. And so in my expansion of my ongoing study, I'm really trying to diversify my sample, and that includes geographic location, socioeconomic status, education background, race and ethnicity, and gender. And so this is something I'm really actively trying to improve upon. So the timeline for this study, there was a 2 time point visit. At time 1, I did complete a full neurocognitive battery. It is a online testing, and then I do a neuro-linguistic testing. I am a speech language pathologist, so looking at that communication and language is something I'm interested in. And then we provide health education. And this visit is truly trying to model a primary care physician or an assessment period. So we assess someone first, we provide the education, and then depending on which group they're in, they're either just receiving status quo education, they get a handout, then they're sent on their way, or the experimental condition spends much more time talking about that education and how to implement it. And that's the area that I don't touch on a lot during this presentation, but I'm happy to talk about my intervention a little bit more. But I really looked at changing how that health education was provided and what kind of outcomes we saw. So for 3 weeks, participants track their own behavior based on what they decided to apply from that health education, as well as reflect on how that session felt to them or how they wanted it to go. So time 2 is in an interview format. They can talk to me on the phone or via Zoom. And I ask questions about how did you apply the health education material? Did you apply it? Why not or why? And then how did you feel about that visit? Was it structured how you normally get education? Was it not? What was different? What could be better? And then also just asking questions about how older adults might want education being provided to them. I do also provide member checking. This is a mixed method study, so I provide member checking. So after the interview, I send back the transcribed interview that I might have coded and ask to see if I interpreted it correctly. So we do involve our participants at every level of the analysis and the results. The intervention session, like I said, there's 2 time points. At time 1, it lasts an average of about 2 hours. This includes the hour-long neurocognitive assessment, and then the intervention period, which can last anywhere from 15 minutes to an hour. Again, in that experimental condition, we give much more space to have natural conversation, to really talk about how health education is typically provided specific to fall prevention, what people might want to see. We allow that conversation to occur naturally. And that's what might lead to this longer time point. Time 2 occurred approximately 25 days after time 1, and it lasted an average of 65 minutes. But typically people met with me for about 15 to 45. However, there were several people who wanted to talk more. And again, I allowed that space and that time for people to give me their feedback.
Should we freeze on
Again,
us? Oh, Amy, are you frozen? You froze for like a minute maybe, or now you're kind of glitchy.
This. Is there a question?
No, there was
Okay.
no question, but you're kind of freezing
Okay.
up on us. I wonder if do you want to try shutting your video off? Sometimes that helps, like with your bandwidth, like
Yeah, absolutely.
maybe that will work.
Okay, is this any better?
There, yep.
Okay. So I'll start over on this slide.
Sorry.
So
Yep.
no, it's okay, thank you.
Yeah.
So you can see here the handout with the 4 things, or a part of the handout with 4 things that you can do to prevent. Oh, did it completely disappear?
You're still here. We can still hear you and everything. I just moved you. Yeah. So I didn't
okay.
be on there. People thinking I'm talking and you're.
Oh, no, it's okay. I shouldn't have shut
We're all
down.
still here. I promise. We can hear you.
So this is the 4 things that were recommended by the CDC handout. But for my study, it was just to focus on making your home safer, or making their home safer. And again, I talked about this intentional access to recommendations. And so making your home safer is something that is low to no cost for the recommendations that we provided. Having a healthcare provider, having referral to a physical therapist or to other providers for eyes or feet might not be accessible to all people. And although that is a big barrier that we talked about a lot in our interventions and with the interviews that I did with people, I really wanted to make sure that I provided information that most people could access. So these are the top 7 things that older adults considered important to do to make their home safer. All people in the intervention picked different things that they wanted to attempt to do over the 3-week period. But these top 7 are what were considered the most important. And so of our 16 participants, all of them had one of these. Some of them had more than one. So the first one is having proper footwear. This is wearing stable shoes, things that provide enough support for the older adult's foot. Proper footwear can be assessed by a podiatrist and be recommended. However, that transition from, this is a quote from one of our participants, from cute shoes into something that is more stable is something that our older adults really focused on and felt was important. The next one is having awareness of stability inside and outside the home, like in parking lots or at curbs. Also when they're getting on and off the toilet or in and out of the shower. That's an example of awareness of stability. So having that conscious thought about how to be safe in those situations. And then clearing pathways daily, making sure there's not clutter or pet items, those sorts of things. A common occurrence that I saw was also when someone takes off their shoes, they put their shoes in the doorway. And so consciously moving those out of the way was something that people wanted to focus on. Some of the other top ones were buying non-slip mats for the bathroom. This is pretty self-explanatory, but there were several people who did not have those. Rearranging closets and kitchens, so most commonly needed items are closer to waist height, so they're not having to dig around or stand on ladders or bend over, all of which can induce falls or instability. And then finally adding sensory lights to the bathroom, to stairs, to entryways or exitways. So these are the top things that our older adults felt they would do. And many were successful in monitoring their stability or wearing proper footwear, doing things that were repetitive or one-time things like adding the sensory lights or buying non-slip mats. And so being provided that education on what they could do, many older adults did end up doing these things. So we did have some other recommendations that we collected from occupational therapists and physical therapists, and we provided them as options that older adults could do. And so the pink on the left side of the screen are what we just went over, the top 7 that older adults felt they would do. But the other side, the other 7 are what OTs and PTs recommended. And we provided on our list of what older adults could pick from on how to make their homes safer. And so removing throw rugs was up there, is up there on one of the top importance. So this is number 8 here. So if this is 7, this would be number 8 of removing the throw rugs. Turning lights on at night. This was something that many people had adverse reactions to, but they still felt was very important. Having chairs or rest stops around the home was next. This talking to loved ones was more about like sons or daughters and or grandchildren, how to communicate with them of needs they might have or physical limitations. That's what talking with loved ones means. And sometimes this can be a first step for people when they're not sure how to change their home or how to change their environment, is to talk with their loved ones about what they could do. The next one is using a bathroom routine to combat urgency. This was something that a lot of people found curious and ultimately really enjoyed for those who picked it as their thing they wanted to try out. And I think it's a great suggestion also. The internal checklist is like the steps for when you get in and out of the tub or from standing up from sitting. This is to combat low blood pressure. So you have that moment to pause and let your body catch up. That was something else that was recommended. And then using an assistive device. Most of our older adults not have a recommended assistive device, which could be reasons why this is rated as the lowest. Although it is very important by Ts and OTs and recommended by providers, our sample did not have assistive devices recommended to them, at least based on their self-report. So this might be one reason why it's rated as the lowest. So I have some quotes here from our participants. The one on the left is a person with brain injury, and the one on the right is a person without. And this was just reflections on why they feel fall prevention is needed, and so or health education on fall prevention. And so our person with brain injury said, "I'm not the only one who probably doesn't really want to identify what might be a trouble area or admit if I lived alone. I really wouldn't want to admit it to anyone. I'm clumsy around the house because, you know, I drag my foot a little or something like that." And then the one without brain injury talked about similar things by saying, "I need to pay attention to these things as well because I have terrible balance and I'm an accident waiting to happen. So I need to figure out a way to make this work so I can stay independent." But that was a real eye-opener for me to realize that I truly am at risk for falls. Whether I want to accept that or not, the bottom line is that I am at risk. And so one thing that I really enjoyed about this study and doing this work is the opportunity to give that space to people to really think through their own thoughts and beliefs about health education and how they might want health education. And something that I found effective was giving that power back, asking about what on this list do you feel you can do, instead of just providing it in a way of you should do these things. Instead, it was, what do you think you need to do and why? And so we really had these rich conversations, and a lot of it turned into, I don't want to admit these things, or I don't want to do these things. And so by providing a way that someone can do it independently, appeared to be very successful. And I got a lot of enjoyment out of it. And I think my participants did too. So I am going to plug a little bit for my study. Again, I know that this is mostly providers, but one reason to participate for this is that older adults with a history of brain injury are at risk for future falls and decreased cognitive decline. And I want to make sure that healthcare providers give appropriate health education in a way that is useful to patients, particularly those who might have different ways of thinking, different ways of being able to process information, different ways of engaging in prevention, and this could ultimately contribute to that self-management of care. So for this study, to be eligible, someone has to be 65 years or older. They have to have a computer or a laptop with a keyboard or access to one. That's for that neurocognitive testing. They must have Zoom and the ability to share their screen or share their face and be comfortable with that. And then no more of mild cognitive impairment or mild language deficits, which I do screen people for. So if someone is unsure, that's the first step to the study is I provide information and do some screening. So if someone is interested, I will put a link in the chat for you to enter information, and I can send you an email, or you can just email me for more information. And then finally, I'm happy to answer questions. I also have on here my social media and my personal website. So I do self-archive all of my papers. So when I publish this, you can go to this website and read my paper free to cost to you. So any thoughts or questions? I'm going to leave the screen on my flyer here in case anybody is particularly interested. And then I will put my information in the chat. Any thoughts?
Perfect.
First off?
Any questions, any thoughts,
How old do you mean, like older adults? What is your cutoff?
So it is aged 65 and older, which is what the NIH defines as an older adult. So
Okay.
it's anyone 65 and older.
Okay.
Any other thoughts or questions?
questions? You see you guys trying any of this stuff or recommending someone come to this or? Falls something you see a lot. You could probably try to turn your video back on. We could see what.
Okay. Here, I can also stop share. And then.
Hi, this is Amanda Mitchell.
Hi, Amanda.
Hello. I worked in a nursing home setting as a nurse for quite a few years and other roles. And I know they do at least quarterly fall assessments, and they also focus on if a fall occurs, they do kind of like a root cause to see if there are any updates. So yeah, it's great information to have out there, especially with brain injury, because I think that's really missed in nursing homes because everyone's grouped is the same. So it's very important to get this information out. So thank you.
Yeah, absolutely. I worked in skilled nursing facilities for most of my speech language pathology career, and that was actually my job, is doing a lot of the cognitive assessments for fall risk. So that's what started it all. Yeah.
I have a more like, what do you plan to do after? What are you going to do when you're done with your PhD, or what are your plans next?
Yeah, sorry about my dog. She's in
No,
the
that's
back.
okay. We all are at home
That
mostly.
ex driver. Yeah. So I actually have a postdoc position lined up at the VA. My dog.
Story of my life. It's okay.
Nope. Yep. That is my dog who thinks she's needs to protect
Very
very
tough,
much.
yeah.
The FedEx driver. Yep. So I have a postdoc position at the VA in Chicago, which is the polytrauma center where a lot of veterans go if they have a brain injury. And so I will be learning neuroimaging there,
Very cool.
hopefully to be able to read and use that to implement neuroimaging into a clinic, as far as using transcortical magnetic stimulation. Has anyone heard of that? So my next step is to look at, it's a magnet that has been proven in some cases to increase neuroplasticity in the brain and to help with brain injury recovery. And so it's not approved yet for brain injury, but it's in a lot of clinical trials. And so I'll be the person who looks at how do we make that more appropriate to moving to a clinic, and how can that be used in a clinic setting and not just for research. So.
Very interesting. Good information. We're getting a little bit in the chat.
So I did put our lab website in the chat if anybody wants to spread it to anyone. This has all the study information and then a link to be able to send me an email, and then I'll do the screening from there. So if you're interested
So
in
you can
sharing.
do most of the components virtually, like they don't necessarily have to come to you, right?
All are virtual. Yep.
All are virtual. Sorry, I didn't catch that. You probably went over that, but
Oh,
yeah.
that's okay. Yeah.
Yeah, awesome. Good. So yeah, we'll see if we can help recruit. Now, hopefully I'll get a bunch more people join. Awesome. Thank you for your time, Amy.
Yeah,
Thank
absolutely.
you everyone
Thank
for coming.
you.
Hope you all
Thank
stay
you.
safe in this crazy
Nice
weather.
to see you.
I'm gonna stop recording.